Now we're going to have the next case for presentation, which is also a classical long case that you get in the exam. It is about a gentleman with features of jaundice, and it will be presented by Dr. Salim Javed. If you have any questions, queries, you can mail or post it later on. Now, Dr. Salim, are you ready with your case?
Yes.
Okay.
Good afternoon, everyone.
Speak loudly,
Salim
please.
Javed, presenting the case of Bachchan Das, 55-year-old male, resident of Madhubani, Bihar, farmer by occupation, presented with chief complaints of itching all over the body since 4.5 months, yellowish discoloration of eyes and urine since 4 months. In the history of presenting illness, patient was apparently well 4.5 months back when he starts having itching all over the body. 15 days later, he noticed yellowish discoloration of eyes and urine, which is insidious in onset, painless, progressive. It is associated with 2 episodes of waxing and waning. One is 1.5 months earlier and another is recently. It is associated with history of fever with chills and rigors. There is history of weight loss and loss of appetite. There is no history of past biliary colic. There is no history of hematosis melena or vomiting. There is no history of bone pain, severe headache, hemoptysis, cough, or spine pain. In the past history, there is no history of chronic comorbidity or blood transfusion or surgical intervention. This personal history: patient is non-vegetarian by diet. Sleep pattern is normal. Bladder bowel habits have already explained in history of presenting. In the family history is not significant. There is no treatment history.
What would be a significant family history?
So it is contributory to the.
In this case, what would be a significant family history, Mahinder?
So the history of jaundice in congenital jaundice in family, or a history of abdominal malignancy in family.
Which abdominal malignancies run in families?
Colonic carcinoma.
And what is HNPCC syndrome?
Hereditary non-polyposis colorectal cancer.
What are the various cancers that are covered in this?
Dermatology,
Duodenal,
gastric, breast,
pancreatic.
pancreatic,
Right.
periampullary,
There
pancreatic.
can be a significant family history if you ask those questions. What are the other significant family histories that you would like to take? Can there be a history of breast cancer which would be relevant to a colorectal cancer? Pancreatic cancer? Which gene? BRCA2, which is linking both pancreas as well as breast. Male breast, usually more common. Anything else in the history that you would like to know, Abhinav?
History of prodromal symptoms.
There is no history of any prodromal.
Why is it important, Salim?
We ask for the rashes and arterial
But why is it important?
medical to rule out medical jaundice.
Yes, to rule out hepatic jaundice. And what are the prodromal symptoms that you ask for?
So any malaise, any weakness, lethargy, anorexia, itching, pruritus.
No, itching pruritus is not a prodromal
So
symptom.
lethargy, weakness.
Basically features of viral
Viremia.
viremia, that's what you ask for. Okay, what else is missing in the history?
So there's one doubt. Last time the examiner stopped me on this, that why are you interested in, since it's a long history of around 5 months duration, then do you expect it to be viral hepatitis?
No, I'm not saying that it is viral hepatitis.
Then
And
why do you need to mention it?
you may get another person this time. So, no history of prodromal symptoms, no history of blood transfusions, you asked. It's 5 months now. Is there any point in asking a history of blood transfusion? How would blood transfusion be related to jaundice?
Chronic hepatitis.
So there are questions which will always remain alike. And if he says, if the examiner says he's asking question, and the examiner said 5 months old, why are you interested? Okay, not interested. Because you can't tell him that you must be joking or you so and so. Or why don't you start reading now, although you lost the plot already. You can't tell him all this thing, although you want to. So that's a day to hold it back. But definitely tell him some other time. Forgive but don't forget. The reason is simple. Lack of awareness is also a dangerous disease, you know. Ignorance kills everybody else also. And the person is in charge of things, so he'll make a mess of it anyway. So let's move on. Let's not waste time. So he's taken a complete history. Any questions pertaining to that history?
History of high risk behavior.
History of high risk behavior was missed. Why?
Related to hepatitis transmission of hepatitis.
6 months old disease, why should you bother about high risk behavior? Should we or it should not? Abhinav? What does 6 months have to do with any history? Every history is important. Where a patient with hepatitis can have symptoms lasting for 3 years. Hepatitis is not only viral hepatitis, there are so many other conditions which are linked to it. Clear? So what would you like to take in the history?
Another history of passage of clay colored stones.
Told there is
That he mentioned.
passage of later.
And history of melena. No, your history is good. I'm just trying to make it better. He also took history of melena. Why is that important?
Malignancy, there is upper GI bleed, to lead to
So only upper GI bleed will produce melena? You mean if there is a lower GI bleed, there won't be any melena?
there can be
How will it happen?
the bowel motion is slow, decreased, then it can lead to melena.
The bacteria can act on it and produce melena. So it depends on the flow of the movement if the patient is chronically constipated. In colonic malignancies, which side colonic malignancies produce melena?
Right
side.
Right side.
The left? How would left produce melena? Right sided road, cecum primarily, because there is a long transit time. It has to move also for the bacteria to act. Right? Is that okay? Let's move on. Any other point that you'd like to know in the history?
Examiner says that why are you interested? Why did you ask for melena? Then can we straight away proceed to say we are interested in ampullary variety?
No, we don't say anything. We simply say melena. I don't know which exam. Now you don't irritate me with the examiners of
So
all
that's-
types. Now I'm coming to the point which is relevant. Melena is a positive history. If you don't take it, it's a negative point. The next question is why melena is important. We have discussed it. You do not know that this jaundice is obstructive jaundice due to periampullary carcinoma as of now. There are so many other causes of jaundice. Cancer colon leading to porta-hepatis nodes, blocking it can also lead to jaundice. Cancer of the colon leading to metastasis to the liver can also produce jaundice. Cancer of the stomach can produce porta-hepatis nodes and produce jaundice. So we haven't yet come to that, therefore history of melena is important. Any history of steatorrhea? She was asking about clay-colored stools. So clay-colored stools don't exist. Because for that you have to know
So there is history
the
of
color of the clay. Because clay comes in all sorts of colors, so one has to be careful. Can we move on now to the examination?
general medical examination. Examined the patient after taking well-informed consent in well-lit room after adequate exposure from chest to mid-thigh. Patient is conscious, cooperative, sitting comfortably on the couch. Hydration is adequate. Nutrition status is poor on account of pallor and BMI.
Which is the BMI?
90.
90 is okay. But pallor is.
Pallor on account of pallor. Performance status is 90 by Karnofsky scale. Vitals are normal. The pulse rate is 80 per minute in right radial artery. Normal in rate, rhythm, volume, no specific character. Blood pressure is 120 by 86 in right arm supine position. There is deep icterus present, pallor present, no clubbing cyanosis,
Where did you look for pallor in this patient?
soft pallor,
In the crease of the palm.
crease of the palm. No raised JVP, no signs of liver cell failure,
What are those stigmas of liver cell disease?
loss of hair, loss of loss of hair, metriosis, that is lateral eye growth, palmar erythema, caput medusa, fetal hepaticus, gynecomastia, testicular atrophy,
Yes, you speak loudly.
spider nevi, caput medusa.
So rattle them out from top to bottom.
So metriosis, parotid enlargement, then spider angioma, then hepatic cases, then tremor of hand, flapping tremor. Then
There's so many.
Retinicia, leukodystrophy.
So he is very rightly mentioned no stigmas of liver disease, so that the examiner can ask that question and he can answer that. Good. Let's move on.
There is scratch marks present all over the body.
Which is important.
No other or generalized lymphadenopathy present.
What is a generalized lymphadenopathy? Salim? Define generalized lymphadenopathy.
It is involving more than two groups.
So involvement of two or more than, you said involving two non-contiguous lymph node regions. So if there are three,
More than two or more than
so more than two or more than two non-contiguous lymph node regions involvement is called as generalized lymphadenopathy, and it's significant, so it's important. Okay, let's move on.
On in local examination,
No, examination of abdomen.
examination of the abdomen on inspection. Abdomen is normal in shape. All the quadrants are moving well with respiration. Umbilicus is normal and central in position. No visible peristalsis. No visible peristalsis pulsation. No scar mark, dilated veins, pigmentation, sinus fistula. Renal angle is free. Anal orifices are normal. Genitalia is normal. Supraclavicular fossa is normal on inspection. In the palpation, on superficial palpation, abdomen is non-tender. Local temperature is not pressed. There is intra-abdominal, intraperitoneal lump of 4 into 4 centimeter in size in right hypopendrium, extending 4 centimeter from right costal margin, moving well with respiration. 3 sides of the lump is well defined. However, upper margin is merging with right costal margin. Surface is smooth, firm in consistency. Liver is percussion of liver is it is from 6th intercostal space. And no other organ.
How much is the liver span?
12.
You cannot measure the liver span because it's not as the lower part is not built.
But you can purchase the lower body.
12 to 15 centimeters.
So lower quarter is
That doesn't mean you won't have a span of the liver. It's not enlarged only because you know the span.
so
We'll ask you to demonstrate all those signs as we go there. Carry on.
So we have to tell the full liver.
The liver span is how much? Upper border, 5th intercostal space in the mid clavicle line, 6. And the liver span is normal. You should have done it. Percuss it and stop where it stops. It has to be there. Span to hoga na. You may not. It has to be there. Okay, let's move on.
There is mild free fluid in abdominal cavity, no other organomegaly.
There is free fluid in the. There is free fluid. Shifting dullness is present. That's all issues. Mild or moderate, we will decide. Okay.
So renal angle is free.
Renal angles are free.
Renal
Okay. How did you look for renal angles?
So we palpate in sitting position. We palpate from the back.
From behind.
From
In
behind.
a sitting position. Okay.
Is lower border of 12.
That's okay. Let's move on. What else?
Anal orifices are normal, genitalia is normal, and the palpation of supraclavicular fossa is normal. And digital rectal examination is normal.
Why did he do digital rectal examination?
In abdominal malignancy, to put any free fluid in pouch of
Can he have a pouch of Douglas?
Rectovesical pouch.
And
And sir, bloomer shell.
what is bloomer shell?
Drop malignancy. Drop metastasis.
It deposits. So
Metastatic
that's
deposit.
rectorecycle pouch. Anything else that you would like to look for? You would like to look for a primary in the rectum. You would like to look for bloomer shell. And then when your finger comes out, you would like to look for color. So what is the color like? What is the color of this stool like? Why do you do digital rectal examination in all these patients? One, to look for any primary in the liver, in the rectum itself, or deposit in the rectovesical pouch, or free fluid, which is mild free fluid as you're saying, in a supine position. And also, when you bring your finger out, you can look at the color of the stool, that the staining. Okay? So you didn't find anything significant. Okay? So what is your impression?
55-year-old gentleman with obstructive jaundice, probably of malignant nature,
Due to?
due to periampullary
Okay.
ampullary variety of
Same.
Yes. What is a CAGB? Carcinoma of gallbladder also. We got stopped. This is his diagnosis. She said it can be carcinoma of the gallbladder also.
So there won't be any waxing and waning in carcinoma of gallbladder. Plus there is a history of
See, whenever you're answering the question, go back to the same drill. Points in history and points in examination. Now, what are the points in history against carcinoma of gallbladder?
points in history is sir, history of waxing and waning.
Waxing and waning of jaundice, okay?
Waxing and waning of jaundice.
Any other points? Mahinder?
Male sex, there is no history of previous biliary colic. and-
No history of previous biliary colic, one. What is the incidence of gallstones in cancer gallbladder? Shamishka. You mean, so 90% will have gallstones with it. So about 80% will have biliary symptoms, one. Number two,
There's a long history of 5 months, so gallbladder patient won't be surviving. So
Four and a
the
half.
average with the gallbladder cancer with jaundice won't be
what do you mean
surviving.
by gallbladder cancer producing jaundice, Shamishka? No, the question is valid. I am asking you to answer it. What do you mean by cancer gallbladder with jaundice? How does cancer gallbladder produce jaundice? Manish.
Sir, in case of the carcinoma gallbladder, sir, there is first the metastasis and due to metastasis in the lymph node of Lund, sir, the outflow of,
Which lymph nodes produce the jaundice?
sir, the obstruction due to the normal development of Lund, it causes obstruction.
Lymph nodes and porta hepatis.
Because of retrograde.
Pressure of the
And how long is jaundice early in cancer gallbladder or late? Now the patient presented with jaundice, and how long will a patient, so a patient with carcinoma gallbladder and jaundice due to obstruction at porta hepatis is usually not a resectable disease, it's a failure. To live with that state for 6 months is a long period. But it takes longer for patients of cancer gallbladder to develop jaundice. Why is it so, Salim?
Because of retrograde involvement of lymph node at porta.
The lymphatic drainage of cancer of the gallbladder is slightly different from what you observe in other organs. It first goes down to the celiac axis, then ascends up along the peridocal nodes. So it is long before the porta nodes are blocked. The jaundice can only happen earlier if there is a growth involving the neck of the gallbladder, which infiltrates directly into the hepatic duct. Otherwise, jaundice is relatively late in cancer of the gallbladder. Now, does that explain why it cannot be cancer of the gallbladder? Other reason why it is not likely to be carcinoma of the gallbladder is that there is no history of biliary colic in the past.
Yes.
And to have an absolutely silent gallbladder with stones for so long and then cancer is unlikely. There's something very important in the examination which should be relevant, which you're missing out.
Gallbladder is not hard, it is firm in consistency.
If the gallbladder itself was diseased, it rarely retains its shape. It becomes a gallbladder mass rather than a gallbladder lump. It is a palpable gallbladder which is because of its shape that you're calling it gallbladder. You're calling it gallbladder because of its location, piriform shape, mobility, all borders being palpable and continuous with liver dullness. These are the reasons why you're calling it gallbladder. And thirdly, he will take the support of Courvoisier's hypothesis and get you completely out of the game. What is Courvoisier's hypothesis? Manish Kumar? Shamishta?
In a patient of obstructive jaundice,
Speak loudly, we can't hear you.
in a patient of obstructive jaundice, if the gallbladder is palpable, the disease is not due to gallbladder. Not due to gallstone.
The underlying disease is most likely cancer.
In a patient with the surgical jaundice, if the gallbladder is palpable, it is seldom due to the gallstones.
Now, in a patient of surgical jaundice, if gallbladder is palpable, it is not.
See, I would like it to, we call it obstructive jaundice. Don't try to become very clever and necessary. It's not the right way to describe.
Gallbladder is palpable, it is not due to stones, because in stone disease get contracted.
It is less likely to be due to the
biliary tree because of.
The complete thing.
So in a patient of obstructive jaundice, if the gallbladder is palpable, it is not due to stones. It is most probably not due to stones, but due to distal obstruction of the biliary tree, most probably by periambulary carcinoma.
That's better. It's most probably, because it's a hypothesis. Don't say never due to. That's a wrong statement. In a patient with obstructive jaundice, if the gallbladder is palpable, it is seldom due to gallstones, as they would have produced cholecystitis with shrinkage of gallbladder, unless there is a double impaction of stone or there is a primary bile duct stone. It's most likely to be due to a distal obstruction of the biliary tree by a growth, which could be periambulary carcinoma. So that also goes against it being carcinoma of the gallbladder. I think that issue settles. Let's get to the diagnosis now. Give us a diagnosis. Again, 56-year-old
56-year-old gentleman
with obstructive jaundice, probably due to periambulary carcinoma. That's it. Now the variety we will discuss. Periambulary carcinoma. Why do you say that? I'll ask you the question and you will answer. You already answered that, but what did you say about fluctuation?
So, there is a history of fluctuation in
Now, is that enough? I didn't entertain this thought, this statement. What else should happen along with this drop in jaundice?
So it should be possible for
Passes of melena.
So melena along with it, because the sloughed out content has to be passed down. So in the ampullary variety of periambulary carcinoma, you will have drop in jaundice levels due to sloughing out of the contents through the gut. So that history has to be taken along. Now let's go on to the approach. Any differential diagnosis, Salim?
this patient with benign
Mahinder,
Do some benign etiology like choledocholitis.
why do you think it is malignancy? You said due to malignant cause. I am getting to you only.
the history points in favor, age of the patient,
Right?
this duration of the symptoms,
Yes, short duration.
short duration, some history of waxing waning,
Progressively increasing
there
jaundice.
is loss of weight,
Painless jaundice.
painless jaundice.
You see, the progressive painless jaundice is most probably due to malignancy. Wherever there is a stone, it cries. If there is a stone, there will be pain.
So he's asking for differential diagnosis. Shall we give or not for some benign etiology like choledocholitis?
I am coming to that, but before that, it's a malignancy because of it being the age, you're right, progressively increasing, painless jaundice. Fluctuation is in favor of stone usually. Charcot strat, so that's not a very strong point, so keep your wicket dry. Just don't say that. Just keep it up your sleeve. Third, on examination, palpable gallbladder. Unless there is a double impaction of stone, it's not seen. And double impaction is very rare. Okay? Double impaction or Chinese liver fluke infestation or primary bile duct stones, they're not so common. So commonly it is malignancy. On examination, palpable gallbladder. Performance status being poor, BMI not very good. Patient is actually being consumed by the disease, catabolic. Right? Important. Now, what were you asking? Should we give a differential diagnosis? Now the differential diagnosis here you can utilize because some of your friends don't know what is periampullary carcinoma. So you can make it into, say, it can be head of the pancreas, it can be ampullary variety of the periampullary carcinoma, it can be a duodenal variety of the periampullary carcinoma. They will think you have given 4 differential diagnoses. I would have killed you. But since you asked me that question the other day, Abhinav, so I was concerned. When somebody told him that head of the pancreas doesn't come under periampullary carcinoma, then poor fellow, what does he have? He doesn't have a choice. Get my point? Now, what is a periampullary carcinoma? Define a periampullary carcinoma.
Any growth in the region of ampulla greater within 2 centimeters.
I think that's fine. Now this can be there for head. It can be lower end of CBD, which is cholangiocarcinoma. It could be duodenal. How would the duodenal type present, Nikhil? The duodenal type of periampullary carcinoma, what will be the symptoms like?
So might present as an obstruction.
So gastric outlet obstruction will be the symptoms. Ampullary variety with fluctuation in jaundice, with melena happening alongside. With the head pancreas, more of symptoms of pain, backache, etc. Then you have the 4th variety which we were referring to. I forgot actually, somebody moved. Cholangiocarcinoma with the jaundice being more severe. And features of cholangitis, that is Charcot strat, etc. can appear early. Anyway. But there is very little to pick from each one. Which one should have the best prognosis? Duodenal variety because it presents early. Anyway, there is hardly any difference. The prognosis of periampullary cancer in general. How much is the 5-year survival rate?
3 months.
No, 5-year survival rate in question is 5-year survival rate.
It depends upon
the
Generally speaking, less than 20%, 25% is the maximum. So what are you talking about? The difference would be very limited. The moment it is palpable lump, you are dealing with an advanced disease. Not in this case. Well, having said that, it's a range. When you say somebody can live for 5 years in 20 out of 100, it's not bad news. It's a bad cancer otherwise. Let's move on. How do you approach this case now? So the differential diagnosis to cover you up would be those 4 things which otherwise to me mean the same. Okay? But there can be a head of pancreas which is beyond those 2-3 centimeters, which can be an isolated different cancer. But the others usually fall in that variety. Clear? Okay. Any questions, Shamishta? Mukesh? Manish? Let's move on. So how do you approach this case?
I would like to investigate the patient, investigation to
Now,
support the diagnosis, investigation to stage the disease, and investigation to treat the patient.
confirm nahi karenge.
Confirm the diagnosis, stage.
So what do you do for confirming, what do you do the investigation? What investigation would you do?
Ultrasound abdomen.
That won't confirm the diagnosis. So I'm just trying to be a difficult examiner for you. So why should you do ultrasound first?
Sir, to know the site of the origin site and lymph nodes, any fluid, secondaries in liver, biliary trees.
Okay.
It is initial investigation which can be done and later confirmed by CCT. It will tell about the response very accurately and any fluid in the abdomen. And
Dilated intrahepatic dilated.
We can show you about the dilatation of the duct. And in any case, remember, ultrasound is now considered an extension of clinical examination. It is the stethoscope of a surgeon, so you should use it routinely. It is non-invasive, cost-effective, and it will tell you the organ of origin. It will tell you whether there are lymph nodes in the porta and around it. It will show you about gallstones, which they were having a doubt about. It will also show you at what level, till what level is the common bile duct dilated. It will also show you the condition of the intrahepatic biliary radicals, extrahepatic biliary radicals. It can give you a rough idea about the pancreas also, although it's not the most sensitive investigation for pancreas. You need a contrast enhanced CT scan. And there is nothing to lose in an ultrasound. Ultrasound is an easier way to get an impression of the patient. And it will also show you about the free fluid. Right? What next? If you see on ultrasound that there is a doubtful mass in the region of pancreas, can you put in a needle and do the diagnosis by doing an ultrasound guided FNA?
No, sir.
Why?
Because of complications, vital structures.
Adjacent vital structures like supramesenteric arteries. Any other reason why?
it may lead to hemorrhage, may lead to seeding of cells, and if the growth is resectable, it may turn into unresectable after seeding. So better.
It may change the stage, that's what they say. In gallbladder and head of the pancreas, that's a confusion. In gallbladder, if it's a resectable cancer, by putting in a needle, you can make it into a non-resectable one by converting it into a stage 4 disease, although it's controversial. So stay out of it. You don't need an FNAC to operate a patient with cancer head of pancreas or periambular carcinoma. You may be surprised later on, that's a different story, but it's not done as a routine. What are the indications for doing fine needle aspiration cytology in a patient with periambular cancer?
The growth is unresectable, and we want to start neoadjuvant chemotherapy.
If the growth is unresectable, we are not giving neoadjuvant chemotherapy, we are giving primary chemotherapy. Neoadjuvant chemo, if the patient is put in, if the patient is being put on neoadjuvant protocol, number one. Number two, if you are planning an alternative modality of treatment. And number three, usually suspicious diagnosis, usually tuberculosis in this part of the body. Otherwise, there is no role for doing FNAC. What is the next investigation you would like to do?
I would like to do CCT abdomen.
CCT abdomen for contrast enhanced CT scan for looking for the extent of the growth, site of the growth, look for the pancreatic head, etc. Next.
Sir, if I'm finding ascites upon examination.
Yes, that was the next. I forgot that question. If there is free fluid, can you tap the fluid and get a diagnosis?
Yield is very low, sir.
Very good answer. Yield is very low, and like I mentioned during the earlier discussion, FNAC, negative FNAC does not make any difference. It has a false negativity, so we don't associate anything with the negative FNAC. Only positive FNAC is relevant to us. So it is not something we do as a routine. However, in an unresectable disease, it serves as an alternative way to, and if there is ascites, which is huge. Is there any situation where you would not do a contrast enhanced CT scan after ultrasound, Dr. Salim?
So it's advanced in operating cases.
So if you're dealing with liver has got multiple metastases, there are peritoneal deposits, there is a huge mass which is non-resectable. There is no reason to do a CT scan. There is nothing to find really, because it's a stage 4 disease already. You don't do a contrast enhanced CT scan after that also.
So the treatment
Any role of upper GI endoscopy?
So upper GI endoscopy we can see every variety of.
It is mandatory. With a side viewing endoscope, we do an upper GI endoscopy. You can do an endoscopic ultrasound, and you can also do an endoscopic ultrasound guided FNAC, and you can actually find out
Surrounding lymph nodes and the mass.
status of the lymph nodes around the pancreatic head. Naturally, endoscopic ultrasound is an option. And if you can get a biopsy, especially in duodenal variety and ampullary variety, you can actually get a biopsy. It's useful. Next, you were saying something like, move on.
Do we mention contrast and then CT scan with this patient? If we are getting ascites and if it is confirmed on ultrasound. then
If
we
you
need
mean if it is confirmed on ultrasound to be malignant.
If ascites is confirmed to be present.
Ascites in patient with obstructive jaundice occurs due to non-malignant reasons also. How? That's a question.
Hypoproteinemia.
Liver cell failure.
Liver cell failure, besides that, portal pressure, we have portal hypertension, pressure on the portal vein. You saw the other case the other day. Now, there are so many, there is a portal congestion, and they also have reactionary ascites. So ascites is not a contraindication to any definitive surgery. But if it is a malignant cells you're getting, then there is obviously no reason to do it. Next,
Sir, then LFT,
please carry on. Liver function test.
liver function
Which is
test,
the most sensitive liver function test?
alkaline phosphatase,
Alkaline phosphatase,
Gamma glutamate.
gamma glutamate transferase, whatever.
Enzymes.
Speak loudly.
Prothrombin time.
Prothrombin time is one.
So, there are for various, for liver metastasis, 5 nucleotide days, and for bone for other organ metastasis, alkaline phosphatase, and for confirmation of jaundice, we do.
Actually, I was asking the most sensitive liver function test, generally speaking.
Alkaline phosphatase.
Prothrombin time.
Prothrombin time is the most sensitive, and transferrin alpha. That's okay. Now, albumin is not a very good test. Why? So, what should be done instead of albumin? Transferrin or pre-albumin? Pre-albumin is more reliable rather than albumin, which is a half-life issue. It's a long half-life. Now, so we'll do a liver function test, complete liver function test for prothrombin time. For other functions like alkaline phosphatase would be raised because of obstruction. Anything else?
coagulation profile,
Yeah, prothrombin time you mentioned, and you do the whole coagulation profile. Who is denying that? What else? So that is liver function test. We want to move on.
kidney function test,
Kidney function test. Why are they important?
sir, hepatorenal,
Let him answer, please. One person answers at a time. Yes.
hepatorenal syndrome.
It's known to happen. Hepatorenal syndrome is a problem, and you're going to do a contrast and CT scan. So you must have a kidney function test done before the contrast and CT scan. If the kidney functions are impaired, you may have to do a non-contrast CT, which will not be very useful. Okay, what else? You please tell me all the investigations so that we can move on.
General
And tell me when you're finished.
Sir, pre-anesthetic checkups, complete hemogram, blood.
So you do the
blood
routine
sugar.
investigation. Now, since time we have to keep to time, how do you work up this patient for treatment subsequently? Do you think he will be requiring surgery?
In this patient? Yes, sir.
What would be the criteria for non-resectability in this patient?
Criteria of non-resectability is multiple liver metastasis, peritoneal metastasis, ascites, involvement of superior mesenteric vessels.
And
Lymphatic mass, lymph node mass, large lymph node mass
Multiple.
report hypertension.
Multiple liver metastasis, distant metastasis, lung metastasis, bone metastasis.
so you would need these investigations to know whether he has got a tumor which is resectable or not. And you have to get his fitness to know whether he's operable or not. The patient should be fit for surgery. Now, based on that, you'll take your decision that patient is for surgery or not. Now, if the patient is in for surgery, how do you prepare this patient for surgery? What do you do to prepare this patient for surgery?
So because jaundice patient is glycogen depleted and dehydrated, so first we have to correct dehydration and restore the glycogen storage by giving 5% dextrose IV. Then to correct the coagulation derangements by giving IM injection of vitamin K or FFP needed. And then sir, antibiotic coverage.
Right. Adding anything?
Apart from this correction of anemia, correction of any electrolyte imbalance.
So divide it into three parts: to correct the hydration, to correct the nutrition, and to take care of infection. These are three things. Correct? Infection, you're giving antibiotic prophylaxis. You're correcting hyperproteinemia by giving support, nutrition, and you're correcting the coagulation disorder by giving vitamin K. So cover it individually. Dehydration needs to be corrected because usually dehydration is what leads to hepatorenal shutdown. And you need to hydrate the patient optimally to ensure that the renal functions don't get deranged, because that's a major killer. Sepsis needs to be taken care of because stasis of the bile leads to sepsis, and that you need to take care of. What are the indications for pre-operative biliary decompression?
In patient presenting with fever with chills and rigor and episode of cholangitis, then or bilirubin is more right, more than 10 milligrams per deciliter.
Patient is in sepsis. There is an anticipated delay in the operation. But the right with bilirubin levels is no more an indication.
Yes, the answer is if the patient is not going in for surgery immediately. Number two, septic cholangitis. Sepsis is a broad term. Sepsis is an indication for biliary decompression. And third is if the patient is going to be put on neoadjuvant protocol again. It palliates the jaundice and pruritus automatically gets palliated because jaundice is also a symptom. So we palliate it to take care of pruritus and also jaundice. Some surgeons use bilirubin levels as a marker, but that is not a criteria anymore. And in any case, some people have an indication as more than 20. More than 20, there is no bile production. There is no point doing it. It's white bile at 20 and beyond. So there, we have discussed that. I am not getting into the preparation broadly of a patient. What are the various points in preparation?
So, preparation for management of the fluid and electrolytes, management of the nutrition, and the management of the infection. Along with that, management of the pruritus.
So what do you do for all these? I've already covered.
For the management of the fluid and electrolytes, I would like to put the patient on the dextrose solution, more on the dextrose solution, and I'll correct the electrolytes, basically the sodium, potassium, calcium, magnesium. For the nutrition, I would like to give the high carbohydrate diet and the high protein diet in view of the hypophosphatemia and depleted glycogen stores, and I would like to put on vitamin K for deranged liver functions. Then I will put on the antibiotics for the infection, and for pruritus I would like to put on antihistaminics.
Pruritus would settle as a jaundice settles. Any other point?
What is the role of mannitol in this?
We are coming to that. Now we have done the nutritional management. Hydration status is being corrected, and we ensure that kidney function tests are within normal limits. Now, if the patient has to go for surgery, some people like to add diuretics to preventing hepatorenal shutdown, but they have no role. The role is limited, and that includes mannitol too. We have used mannitol regularly. The reason being it provides nutrition at the same time, it gives calories at the same time, it's a diuretic. But like I said, the best treatment is taking care of dehydration because it's mostly pre-renal. Okay? And once you've got the patient set for surgery, what next do you do? What surgery are you offering? Pancreatic duodenectomy. Okay? Now, how do you go about it? After we've discussed it, we'll go to the case. And I want you to demonstrate a few signs clearly. Yes.
So, midline incision, we use the assessment for operability.
What is one thing which is recommended now as a routine protocol before you make a midline incision?
Laparoscopy.
So you can do a diagnostic laparoscopy. The final year MBBS students will speak out on that in the exam.
We are not discussing any role of ERCP in this case.
There's nothing like ERCP. No. We have already covered endoscopy. Upper GI endoscopy is not synonymous with ERCP. Please stand up and tell me what is ERCP.
Endoscopy retrograde for angiopancreatitis.
What does that mean?
So we inject a dye.
Now, can you inject a dye in a system which is blocked? What is the answer to that question? What is the risk of injecting? What is the major complication of ERCP? It will cause sepsis, for which we are already worried. The answer is not ERCP. If you hear that, that's a common mistake. ERCP is not synonymous with endoscopy. We have already discussed Apogee endoscopy.
Can you give MRCP, please?
You can do MRCP to look for the thing which is not indicated here.
Because
No.
to look for periampulary region, we can visualize.
We are using side wing upper GI endo. So you can.
So how will ERCP see structures around the pancreas?
For the biliary, you can see the biliary.
ERCP is a loosely used term. I mean, you are not getting the point. ERCP is done to inject and see the study, see the biliary tree. Instead of that, you have MRCP now. ERCP has an advantage of being therapeutic. MRCP is not. ERCP is invasive, MRCP is not. But endoscopy is a different entity, and we do endoscopy, we don't do ERCP here. Pancreatic duct is blocked, so is the biliary duct. How are you going to perform it? So people take it loosely, actually, ERCP as endoscopy, which it is not. They are two different things. What were we discussing? Diagnostic lab. So you put in a scope, look for peritoneal metastasis. If there are peritoneal metastasis, you don't proceed with laparotomy. Plus you can also look for the liver, look for why are the peritoneal metastases not seen otherwise?
CT is not sensitive to diagnose.
Less than 1 centimeter nodules can't be seen by
CT fails less than 1. You need, this is a magnification. So you have a gross look and you can take a biopsy. Okay? Cancer stomach, cancer pancreas, no more or less, they always put it. It's a routine. So that you don't do a laparotomy for nothing. It doesn't close. And then ascitic fluid keeps on throwing. It's avoidable. Through a small hole, go in for a diagnostic lab before you proceed. Right? Let's move on. So you plan to do diagnostic lab and then you open up through the midline, or you can use a chevron incision. Chevron is spelled as? I could hear it. CHEVRON. What is that? What is that incision?
bilateral
Bilateral subcostal, it extends up to
It's a rooftop incision, roof of a hut actually, and it is, you can also use transverse incisions of various kinds. It depends, one has to prefer. I think midline is ideal, no problem. And what are the criteria for resectability now? We've seen no metastasis. Now what do you do? Cauterize the duodenum, then you look for what? When is the cauterization considered adequate?
When we can see
When we can see the left renal vein. And you also then try to look for the portal vein. How do you find it? Superior mesenteric vein, how do you find it?
it's passing in the neck of the pancreas.
in relation with the incident message of the pancreas.
You don't see the uncinate process immediately. You can follow the middle colic and it leads to superior mesenteric vein. And that's a technique actually. You lift it up and you follow it down, you reach there. What is cattle brush maneuver? If you don't know, say you don't know quickly.
So in the cattle brush maneuver, the right-sided column is mobilized. Transverse column.
Along with the duodenum. The whole thing moves to the other side. What is the opposite of a cattle brush? Metox maneuver, which is for aortic aneurysm. So left side is moved. The descending colon and the transverse colon all move to the left side. You reach aorta. From the right side you can use IVC, and also cattle brush is done by some people for doing the Whipple's pancreatic duodenectomy, because retroperitoneal nodes can be dissected, which are supposed to be very important. Okay, then how do you look for, come on quickly, how do you look for resectability? Tell me fast so that we can finish.
So, superior mesenteric vessels or porta at the node.
How do you
at the-
ascertain that? What do? You dissect, and then you pass something and find out. You're taking time.
Encasement of the more than 270 degree encasement of the superior mesenteric vessels. is more than 270 degrees.
So how would you ascertain that? My question is simple, no?
So we'll try to insert a probe or something which goes behind the vessels, and then we'll look for the circumferential, if there's any involvement of the
So for that you need to do a suprapancreatic dissection also now. No? And then you try to link the two. You can use a finger or a Rice tube, or you can use a Kelly's forceps to find out that your plane is free. And if it is free, then you can use a hanging method by putting a tape around the pancreas, lift it up and clear it off from all around. And that is how you proceed. We are not discussing the steps of surgery, but these are essential steps. You perform cholecystectomy and try to take the common bile duct with you. So that also helps you come down along the portal vein, and you find portal vein on both the sides. You create a space in between the portal vein and the pancreas and find out that there is a clear space available, and then you pass a tape, lift it up, and that's how the surgery proceeds. Unsedated process is taken out after you have disconnected the pancreas from here. You dissect it away from the portal vein, and that's a surgery. If this patient was not fit for surgery, what are the options available?
Palliation to relieve the pain, palliation to relieve the jaundice, and palliation to relieve the gastric outlet obstruction.
Very good. What do you do?
So for pain palliation, we can do radiologic intervention, radio-guided intervention radiology to block in the celiac plexus or greater splanchnic nerve. And to relieve the jaundice, we can do stenting of the ampulla. These are
Endoscopic stenting.
Endoscopic stenting. These are two types.
And again, we don't do any ERCP here. Is that clear? That doesn't mean ERCP. It means endoscopic stenting only. Next.
So, to relieve the gastric outlet obstruction, we can do drainage.
How do we decide on surgical versus non-surgical bypass? Relieving. Now, if the patient is expected to live more than 6 months and patient is fit for surgery, you do what is called as a triple bypass, which means you do a gastrojejunostomy, hepatico-jejunostomy, and jejunal-jejunostomy, which is here. That's the stomach. That's the jejunum, DJ, pancreas, and that's the obstruction here to the duct. Right? Now, if the growth is here, and it's likely to cause obstruction sooner or later, which it is supposed to, you have to bypass the jaundice, which is what you were saying. You have to bypass the food, and then we have to take care of the cut itself. So what we can do is, we can take this loop of jejunum, disconnect it from here, it becomes like this, and the end is taken, which you have disconnected, this is the end, it's taken up, anastomosed to the stomach, to the jejunum, to the duct, and then the part 2 is anastomosed to the stomach. And then you have a jejunal jejunostomy. So what it does is, you have the jejunum going up in the form of a roux loop, anastomosing with the common duct, stomach anastomosing with the jejunum here. So 2 anastomosing with the jejunum. And because you have anastomosed jejunum to this, you have to do a jejunal jejunostomy if you are taking a roux loop. Is it clear to all? Anybody who doesn't understand it? The other option is, you can take a loop of jejunum right up, anastomose with the duct, with the stomach, and then with each other. So that the food passes this way, bile passes this way. The food doesn't get into the duct. Now let us see this case, and you demonstrate all the physical signs.
Shape of the abdomen is normal. All the quadrants are moving well with respiration. Umbilicus is central, normal in position. There is no visible peristalsis or pulsation. No scar mark, dilated veins, pigmentation, sinus, fistula. Hernial orifices are normal. External genitalia normal. So, supraclavicular fossa
To look for supraclavicular fossa, put the neck on this side and go in between the two heads of sternocleidomastoid. Feel it against the scalenus anterior. You will feel it here. It is called a supraclavicular lymph node, but it is not. It's in a scalene group of lymph nodes. Okay? Now the abdomen palpation.
So on palpation, on superficial palpation, abdomen is non-tender, local temperature is not raised. There is a single lump of size 4 into 4 centimeter in right hypochondrium, which extends 4 centimeter below the costal margin.
Just show how you palpate it.
So first we have to take consent from the patient.
Taken, everything is taken. Now let's start moving.
बाबूजी पैर थोड़े मोड़ लीजिए to relax the abdominal wall.
It relaxes nothing, so keep that down. There is no muscle from abdomen which goes to the thigh. This is just a ritual. It relaxes the fascia, all right. Okay. You're doing superficial palpation.
I'm doing
So you have to synchronize it with breathing. Yeah?
लंबी गहरी सांस लीजिए.
No. You have to synchronize it. Lamba सांस लीजिए. I will enter when there is expiration, and I'll wait for inspiration to act on my finger. You come and hit. This is your lump which you're referring to. Is the liver also enlarged?
No sir.
You did not check it properly there. That's liver for me. यहाँ लाइए हाथ. Bring your hand. सांस लेते रहिए. नहीं रहिए. Liver is tender and enlarged. Why is it tender and enlarged? That's a lump, and that's a liver for me. How did you look for the fluid?
Start from the face.
Why do you go down to suffices?
About this.
Why do you go to that level?
Sir, to rule out bladder.
Or any midline lump, and also look for the most resonant point, which will serve as a reference point. See? This was the most resonant point. Now where do you go? Right side or left side?
Left side.
Okay, why do you want to go on the left side? Right side, the liver is already enlarged. Then what do you do?
We ask the patient to turn towards me. बाबा मेरी तरफ घूमिए, थोड़ी करवट लीजिए, हल्के से.
Wait for
30 seconds. And we again purpose.
Yes. So it is
Resonant.
present. Look for the liver span. This is your examination question.
We start from second into post.
Start from the second space, keep coming down.
Because of obstruction in biliary drainage, hydrohypothesis.
So congestive liver is tender, and the congestive liver could be congested on account of bile or blood, and infected liver is tender. These are three things, three entities, because if the capsule is stretched, it becomes tender. Now, congestive liver or an inflamed liver is tender. So this is congestive here, but it's smooth and tender, which goes in favor of congestive liver. What does that mean? Patient has malignancy and obstructive jaundice. What does a congestive liver indicate?
Secondary.
Cholestasis.
If they were secondary, the surface would be irregular. It'll have nodules. So congestive hepatomegaly means there is an obstruction distally. There is no metastasis. Let him go. Right? It is important to know. It will take care of even that question. The gallbladder is very clearly smooth gallbladder, smooth liver. So there is a congestion, which means the obstruction is distal. Which means you're right. There is an obstruction at the lower end of CVD. Which means malignant obstruction at the lower end of CVD. Which indicates malignancy involving the lower end of and around CVD. Can be cholangiocarcinoma, can be head of the pancreas, can be duodenal, or whatever. So it is very bloody. But this case will involve demonstration of these signs. No exam is done without physical demonstration or demonstration of physical signs. So one has to be extremely careful on that. Any questions from anybody in this case? Here, Mahinda?
So, in sign of liver cell failure, shall we mention pituitary and icterus?
See, icterus is a sign of liver cell failure, but flapping tremors are signs of hepatic coma. So there is a slight difference between the two. Fetal hepaticus, flapping tremors would not be the same thing as the stigmas of liver disease. So I would rather use the term, there are no stigmas of liver disease, rather than liver cell failure, which is a slightly confusing terminology. And stigmas of liver disease would be starting from the head, sparse hair, icterus, spider nevi, palmar erythema, dupuytren's contracture, clubbing, gynecomastia in a male, naturally, ascites, caput pedicea, testicular atrophy, and pili. But this is not going to be present in all, everything is not going to be present. Any other question? Is that clear to all of you? So palpate this case and look for it. Don't miss liver.
We actually need all three palpated but we didn't found.
I don't know, but I found it. I only alone palpated and I found it. So then, I mean, actually the problem is, it is missed because it's more medial, where you're feeling the lump, medial to that is where the liver is. And you've not done the liver span. Otherwise, when you did the span, you went down and it was still dull. That actually helps you know. Percussion is also a method of finding out hepatomegaly. It got missed out. And the way you are palpating is very likely that you will miss it. You will be gentle with it. During expiration, put your hand and wait for inspiration to happen. Then go to the next, and each time you move by the width of a finger and wait for it to happen. Give your hand some time and brain some time to match. Any other question, Pushpa?
Sir, about classical people and pylorus preserving people, what are the main indications and the complication associated with them?
See, the pylorus preserving pancreaticoduodenectomy, which is PPD, versus classical pancreaticoduodenectomy. The advantage of preserving the pylorus is that you don't have the reflux, which is a major problem of gastrojejunostomy that you have to do, or you're getting to that now, or the